We'll get started. So the National Association of Hispanic Nurses welcomes the National Association of Clinical Nurse Specialists for joining us today about being a part of the next generation of clinical nurse specialists. Leading this session is the president of NACNS, Dr. Mitzi Saunders, who will help us learn more about the field of the clinical nurse specialist and how it can help take your nursing career to the next level. Clinical nurse specialists are leaders in healthcare. Like other advanced practice registered nurses, they are trained in advanced physiology, pharmacology, and physical assessment in addition to their particular areas of specialty. They can diagnose, treat, prescribe, and bill like other APRNs as their state regulations allow. At the end of this session, you will understand the CNS role and the many ways it is operationalized at the APRN level, CNS education and how it prepares graduates, the differences in RN and APRN practice, why a CNS program is the best choice for most nurses seeking graduate level education, and how to identify CNS programs and the next steps to apply. And now I'm going to introduce our presenter tonight. So Dr. Saunders became a certified adult health clinical nurse specialist in 1994, practicing at a level 1 trauma center. She accepted an academic leadership position at the University of Detroit Mercy in 2000 and completed her PhD in nursing in 2006 from Wayne State University. In her research, she focuses on improving health outcomes and family caregivers of patients with heart failure or dementia, improving the delivery of online health education, and increasing the visibility of the CNS role to achieve full scope of practice for all CNSs. Dr. Saunders, a tenured professor, actively leads in efforts that support advanced practice nursing at the local, state, and national levels. She functioned as the secretary for the Michigan CNS Association and was recently elected president of the National Association of Clinical Nurse Specialists. During tonight's session, if you have any questions, please use the chat feature to share them with our presenters. Thank you again, and I will now hand it over to our speaker.
Thank you so much. Those are some bold learning objectives for tonight. So I'm hoping we can get through all of them and you walk away with a much clearer understanding of the clinical nurse specialist. So I just want to say here in the beginning, knowledge is so powerful. And the best thing that you can do when you're thinking about graduate studies and what you want to be in 5 years is to become as knowledgeable as possible. So I encourage you, you're doing the right thing by being here and learning about one of the APRN roles. But there's so many other ways to learn, and make sure that you read all you can, talk to other people who have advanced practice nursing roles, and really understand roles before you make that plunge into graduate studies. So we are going to explore the clinical nurse specialist role this evening. So I went to your website, which was well designed, enjoyed looking at it, and I grabbed one of your goals that stood out to me with regards to this session this evening. One of your goals states, advance the educational, professional, and leadership skills of Hispanic nurses in order to increase the number of Hispanic researchers, administrators, and educators. And that stood out to me because those three keywords, research, administration, and education, are sub-roles of the clinical nurse specialist role. So achieving a master's or a doctorate as a clinical nurse specialist gets you that much closer to that goal. And then we're also going to explore the other sub-roles of the clinical nurse specialist, which is practitioner, not to be confused with nurse practitioner, but sharing the same clinician type skills as a nurse practitioner, as well as consultant. And oftentimes a clinical nurse specialist functions as a consultant. So we are going to move forward with a story. This story is of my mother-in-law named Camille. So this will help you to understand a little bit about the CNS role as we launch forward. On December 29th, 2022, my 86-year-old mother-in-law suffered respiratory arrest, was without a breath for 25 minutes, but revived by EMS and taken to a local hospital. My husband and I met her there and received information on her condition. By the kinds of questions I asked them, they immediately asked if I was medical. And I said, I am a clinical nurse specialist. And I knew what 25 minutes of absent breath meant, and she was likely already gone. She was transferred to the ICU and, of course, on a ventilator. I was surprised to hear that they would begin tests tomorrow, the next day, and in effort to identify a cause for her respiratory arrest, and we're starting the usual cooling protocols. As a clinical nurse specialist, I've had advanced training and experience in these situations. I assessed my mother-in-law quickly to find no response to any stimuli. I knew she was gone. I approached the intensivist who agreed with my assessment, as did the family. And in essence, we needed to take her off the ventilator and let her go. The intensivist agreed, and so it happened. But the nurse assigned was fairly new to nursing and had difficulty judging on the use of morphine and Ativan in the process. She would look over her shoulder at me and ask if she should give more. And I would respond, well, she is struggling to breathe and she looks uncomfortable. So in essence, I was saying, yes, please. But that's one story of how a CNS guides care as an APRN. And that's why I became a clinical nurse specialist. My mother-in-law died peacefully that night and with dignity. But that experience left me with questions. How many patients out there suffer more than they should, along with their families? How many new nurses are not getting the support they need and at crucial moments in patient care? How many patients are left on ventilators for weeks and weeks at a time until someone finally speaks up? I am the current president of the National Association of Clinical Nurse Specialists, an organization for CNSs with the goal to expand the care of clinical nurse specialists to more patients, nurses, and institutions where care occurs. NACNS empowers, elevates, and advances the careers of CNSs as we invest in CNSs to solve the strains in our healthcare system, the nursing shortage, younger, inexperienced workforce, physician and nurse practitioner burnout and turnover rates. All these issues together require strong leaders, and that's the clinical nurse specialist. So let's get started. So this presentation is based on references because data drives everything that we do as a clinical nurse specialist. So we have a statement that we put out every 5 years on CNS practice and education. So I'm using the 3rd edition. I'm also going to refer to the National Council of State Board of Nursing 2022 survey results on nurses. Really gives us a good snapshot of where nursing is today. I'm also going to refer to a Chief Nurse Officer brochure that we produced as an organization last year, and it's just full of testimonials from Chief Nurse Officers who use clinical nurse specialists and can attest to what they provide in terms of patient outcomes. And then I'm going to refer to several Medscape nursing career satisfaction surveys, the nurse practitioner burnout that we're experiencing, as well as, because I know you will ask about compensation for advanced practice RNs. I'm going to talk about that. The American Academy of Pediatrics just came out with their statement for standards for neonatal care, which, by the way, requires a clinical nurse specialist. And then some of the research that I've done on the clinical nurse specialist role. And we will continue on. So there's a lot to unpack on this slide. So first we start with the basics. We know what an RN is, and you're quite familiar with the scope of practice of a registered nurse. So you have to be an RN first to then become an advanced practice RN. So an advanced practice RN is when you get a master's or a doctorate or a postgraduate certificate with a concentration in one of 4 APRN roles. And there's only 4 APRN roles: clinical nurse specialist, nurse practitioner, nurse anesthesiologist, formerly called nurse anesthetist, and nurse midwife. So that's important for you to know in the very beginning. So if you get a master's or a doctorate, if you don't get it specifically within one of those 4 roles, then you are not an APRN, because an APRN then goes on to take a national board certification exam, and then they get licensed in their state as an APRN. And if you're an APRN, in most states, you're able to diagnose, prescribe, bill for services. You could open a clinic. You could do a lot of things because your scope of practice just enlarged to where you're doing some medical, or once medical, now advanced nursing type activities. So as a clinical nurse specialist, we have programs in neonatal, pediatric, or adult gerontology. If you do adult gerontology, that would span from late teens to very older adults, 100 plus. And again, all APRNs have the ability to diagnose and prescribe care. All APRNs work with a special population of patients or a specific setting. But what's unique about the clinical nurse specialist is that we do 2 other major aspects in our role. And those are the last 2 bullets that you see there. So in addition to the patient practitioner kind of role, we also have a role where we are trained to support nurses, role model care, and really know how to work with the nurses to make their behavior change to improve patient outcomes. And then the third part of our role is systems leadership. So we're well trained on how to do a root cause analysis, how to use different kinds of quality improvement models so that we can analyze the way care is being delivered and make changes. So we look at the process from A to B and see what do we need to change in that process so that we achieve a more efficient delivery of care and better patient outcomes. And in doing so, we're bringing the best evidence into practice as we're doing that. So quality improvement leaders, who are the kind of the captains of those projects, really working one-on-one with nurses. And I'll demonstrate that a little bit more here shortly. But those are some of the key differences in a clinical nurse specialist program or role that would be different from the other 3. So just to unpack a little bit of more information here, APRNs make approximately 50% more in salary than RNs. The mean range of salary is $123,000 to $143,000. And we can bill for services, as I mentioned. So all of the APRNs are trained in doing advanced physicals, history and physical exams, making diagnostic statements, medical and nursing, and then writing orders for patients. And most APRNs are at the master's level right now. So about 77% of all have a master's level. Around 20% have a doctorate of nursing practice. And then a postgraduate certificate is for those who already have a master's or a doctorate in something else, and they want to get that concentration as an APRN, clinical nurse specialist, or a nurse practitioner. So there's postgraduate certificate programs for those as well. The other thing I just want to mention is the 3 APRN roles, nurse practitioner, nurse anesthesiologist, and nurse midwife, are very volume driven. They see patients. And sometimes they have to see a certain number of patients every hour because of our payment systems, right, in healthcare. But I would say the CNS is more value driven. We're not driven by volume and we have to see a set number of patients. We tend to go on any given day where we are most needed. So I will continue to demonstrate that in this presentation. So a typical working day for a clinical nurse specialist. So when I'm thinking about as a clinician and as a practitioner, as a clinical expert, I will have a caseload of complex patients, but they're patients that I have found to be most at risk, or a patient that has fallen last night and I need to go see that patient and do a root cause analysis of what happened, or there's a difficult discharge that the nurse needs help with, or a patient family meeting that needs to take place and important decisions need to be made. So we tend to practice more in the here and now. So when you think of those complex patients that you go in and take care of, think about which ones you could have used more support with. Those are when you consult the clinical nurse specialist to help you. Maybe you need to brainstorm about solutions for a patient or a difficult patient and family. So that is when you would use the support of the clinical nurse specialist. And then what we're seeing more of in state legislation is that in 41 states now, CNSs have prescriptive authority. So now CNSs are starting to get what's called hospital privileges, meaning that they can not only recommend orders, they can also write orders. So that is probably one of the biggest changes we are seeing in clinical nurse specialist practice right now. So I would say about 60% of the time, a clinical nurse specialist is practicing this way, being there in the here and now. Where do you need me and where can I support the nurse? So I want to introduce you to Jennifer and Gypsy. Gypsy is the miniature horse that you see on the right, and Jennifer is a pediatric clinical nurse specialist. So one thing about clinical nurse specialists is if you ask them what their work is like, they would probably refer to one to three of the biggest impacts that they did in the last year. Well, if you ask Jennifer, Jennifer will say, I developed this equine horse program that is just really making all the pediatric patients really smile. It's a one-of-a-kind program. And this is where you see the autonomy of a clinical nurse specialist to be able to be creative, to develop programs that they know are going to make a huge difference. That value-driven, right, type of care. So I couldn't help. Gypsy is just too cute. I have to use this picture whenever I can. So now let's talk a little bit about those other portions of the clinical nurse specialist role that I think attract most nurses to become CNSs, because they really, really want to change healthcare. They're not happy with the status quo and they want to work with the nurses. And when I did my work pattern study a few years back I interviewed a lot of CNSs across the country. It was working with the nurses that was most special to the CNSs. So it's working with them with these complex patients to improve patient outcomes. I mean, can you think of times when you as a nurse needed more support in patient care? So it's not just one-on-one, it's seeing where are the patterns, where are the trends, where do I need to create an in-service for the nurses? Where do I need to work on new protocols so the nurses don't have to work as hard? We can streamline the processes, streamline the way we do care, so it eases the burden on the nurses. That is what the CNS does. They empower the nurses to do better and do more, and they're very much there at their side as they're doing these things. The chief nurse officers have had a lot to say about what nurses get out of having a clinical nurse specialist around, and they're really a game changer. They really support what nurses do. And when they're at meetings away from patient care and they're with people who make financial decisions, it's the CNS who really speaks up for nurses and speaks up in a way that if they're trying to change something that's going to be a burden for the nurses, the clinical nurse specialists are speaking up and advocating on behalf of nursing. And so I pulled this statement because I love quotes and testimonials. And in this one clinical nurse specialist annual report, and this was published by Kim Elgin, who is a CNS leader of a healthcare system, and this was published in the journal Nurse Leader. This one nurse manager referred to a clinical nurse specialist like this: the nurses would breathe a sigh of relief when she, clinical nurse specialist, would round. Her collaboration between services eliminated fear of the unknown and gave teams the support to care for our patients outside of our comfort level. Again, that's the value-driven work of the clinical nurse specialist. The clinical nurse specialist is like the glue, right? So you have all these people doing their work around the patients, but you kind of need that one person to go to who is kind of pulling all the services together and knows what's going on. So think about all those times as an RN, first time you lose your patient, first time you start giving comfort care only to a patient, kind of like the story that I told with my mother-in-law. I knew that nurse was new. I knew she was very unsure of everything she was doing. Patient falls. Patient goes septic, your first code blue, you get a trach patient, you've never taken care of one or it's been a while, chest tube care, a difficult discharge, a violent patient, you're getting bullied by another staff member, you're understaffed, COVID, right, really, really challenged us. You know, so you just think of all those times that it would really, really be nice to have a clinical nurse specialist who could really support you and what you do through these difficult times. So systems level expertise. So the CNS, as I said earlier, wants to be a CNS because they want to make change. They're usually not satisfied with the status quo. And we know that there are a lot of messiness in healthcare today. So the clinical nurse specialist has that kind of bird's eye view, broad scope of what's going on, seeing patients just enough to know that there are trends, that I don't like what's going on. We need to improve the outcomes for this entire population of patients. So can you think of patient populations in need of better support from admission to discharge to return for the clinic care or care at home? I know in my CNS practice, it was the heart failure population, particularly patients newly diagnosed with heart failure. It was such a major change in their life to start taking medications and lots of them, to change their diet, their exercise, a lot of things, a lot of education. So that was a population that I really worked with when I was in clinical nurse specialist practice. So you design programs of care, right? You look at a process, again, from A to B. How can we improve the process of care? All right, you lead a team. So a lot of CNSs are very, very involved as this systems level expert. Again, it's a very value-driven role, very autonomous role. We're like investigators and detectives looking for those system issues and consequently end up saving hospital systems lots of money, which is a very important outcome of CNS practice, and improving satisfaction, right, for the nurses, the doctors, everybody involved. So an education for a CNS, it's very similar for the APRN roles. So it doesn't matter in the beginning which role you're all in the same classes together. So there's always more advanced nursing theory, advanced research, healthcare policy, very important, leadership. So those are like courses that you all take together, as well as what we call the 3 Ps, advanced pathophysiology, advanced physical assessment, and advanced pharmacology. But it's really then when you branch off into your specific roles that things change, and you go into clinical, and then you implement those 3 Ps. So you're seeing patients, you're doing H&Ps, you're making medical diagnoses, and you're deciding what you would prescribe for those patients in these mentored clinical hours. Or you're doing lots of change projects, and you're working at what is it like to change the behavior of a whole group of nurses, and you learn the ins and outs of all of that, and it is difficult. Most people do not want to change. So, you know, you go through a lot of change projects, and you monitor how is behavior of the nurse changing, and then what are the patient's outcomes as a response to that change. And you do lots of change projects like that. One example is the failure modes effects analysis that students do in a CNS program, and it's a predictive model. So instead of reacting when things go wrong, root cause analysis, let's, make a change, you are predicting what's going to go wrong. So you kind of have an idea of a certain product we're using or a certain process. We're doing all these workarounds that has got failure written all over it. So we may do a failure mode effects analysis and determine where in that process we need to make change happen before something bad happens. So how is the CNS different from the other nursing roles? So you have the outcomes for a CNS. We focus on complex care. So one of the differences with like a clinical nurse specialist and most of the nurse practitioner roles, with the exception of one, we see complex patients. So a complex patient could be acute decompensated heart failure. Nurse practitioner would see 3 patients an hour, sore throat, ankle sprain, those kinds of patients. So you see a very different level of patients consistently as a CNS versus in most of the nurse practitioner roles. The sustainability of major impacts is important to the CNS role. So when I mention all those change projects we don't just do a change project and then leave it and go away. We oversee those projects over time to make sure that they're sustainable. So that's a key part of the CNS's role. Always collecting data, analyzing data. That's different from the other 3 APRN roles that are very volume focused, very patient focused. Optimal patient care outcomes is the key regardless of what APRN role you're in. But again, much of what the CNS does is more value driven rather than volume. Okay, so that is also a big difference. Another big difference is the Medscape reports, and you can pull these up in the reference list. Of the 6 nursing professions, LPNs, RNs, nurse anesthesiologists, nurse midwives, and nurse practitioners and clinical nurse specialists. Guess who had the highest career satisfaction scores for several years in a row now, going on its 3rd year, and that was even during COVID. Yes, the clinical nurse specialist. And I think I know why, because a study just came out recently that clinical nurse specialists had what we call very high self-efficacy scores during COVID. Self-efficacy means kind of your ability to be able to cope in challenging times. And I think that speaks to the characteristics of a clinical nurse specialist, that you almost kind of thrive when you're challenged. And you have that ability to cope with those challenges, and you don't find challenges to be as disturbing and difficult. So I just thought that was interesting that even with COVID, CNSs were still more satisfied in their career than the others. I think the versatility of the CNS role and the education, when you think of you're trained as a practitioner, you're trained as a change agent, you're trained as a systems leader, and you get all the principles of adult education and how to change behavior in adults, the nurses. It makes you so much more versatile for so many other roles out there. You're not single skilled at education, like a master's in nursing education, or a microsystem level, such as a clinical nurse leader, other roles, or leadership, minus the clinical. You really are well-versed in a broader range of topics. So I don't know if you've heard of Alyssa Shannon, but she is the analog astronaut who was chosen to do the Mars mission, which is a simulated Mars planet in Texas. It was in the news recently. She happens to be a clinical nurse specialist. And I had an opportunity to interview her a few weeks ago, and she really highlighted what a clinical nurse specialist education did for her. And she said it was really the critical thinking skills, just made her think more broadly. And then she practiced as a CNS for a while as well. So I'm not saying you can become an astronaut by becoming a clinical nurse specialist, but it sure provides a lot of versatility for a lot of different roles beyond clinical nurse specialists. So we have a CNS program directory. So we have roughly 60 programs across the country. We have a handful, several online programs that you can attend regardless of where you live. And we have program directors who would be very happy to talk to you about this amazing role. But I would recommend, you're already doing the first step. You're here, you're learning about the role. This is the first step. I would encourage you to shadow a clinical nurse specialist if you can. Preceptors are available across the country. We have CNSs in every single state. So we can help you if you call NACNS or send us an email. We can help you further in this endeavor as well. And the jobs for CNSs are going unfilled, or they're waiting for you. This is such an important role, and we believe every nurse deserves a clinical nurse specialist. Now, these people, we have our national conferences every March, and we took our first selfie at our last conference. These people they're having a lot of fun, but we're like a family. We really are. We are a volunteer-based organization, and we have so many wonderful volunteers. And these are all clinical nurse specialists that you see before you. So it's just a wonderful organization to be a part of as well. So I look forward now to your questions, and if you want to contact me, my information is there, president@nacns.org. My contact information, as well as my LinkedIn profile. And if you go to the NACNS website, we have an Ask Mitzi Anything question at the bottom of the landing page. So feel free to ask questions. Thank you.
Thank you, Mitzi, for your great presentation of the CNS role. I don't see any questions in the chat, but we did have people submit some questions when they signed up for this session. So I want to go ahead and ask the first one. How is a CNS program curriculum different as opposed to other MSN degree options like nursing education or FNP?
Yeah, so if it's other APRNs, they're very similar because you do take many of the same core courses and the 3 Ps that I mentioned, the advanced pharm, advanced patho, and advanced physical assessment. If you are in a non-clinical type master's, like master's in nursing education or a master's in nursing leadership, you will not need the 3 Ps because you're not going on to diagnose and prescribe care. So those courses you would not need to take. They probably would not be part of your curriculum. And then the clinical hours. So at a minimum for APRN programs, you have to have 500 clinical hours. And those clinical hours are really based off using the information you've learned from the 3 Ps, so practicing, diagnosing, and prescribing. So again, that would be very different from a master's in nursing education or leadership, where you do not need to practice those skills. That would not be part of the scope of practice for those master's degrees. So it just depends, so it would depend. If you're APRN, very similar courses, and then branch off at the end for your concentration, okay? Clinical nurse specialist, nurse midwife, nurse anesthesiologist, or nurse practitioner. And then in the others, you may not have clinical hours, or you may have just a small circumscribed number of clinical hours.
We have another question from the chat. Amanda said, I am 2 semesters away from completing my degree and I am lacking jobs in my area. Any advice? I am in the St. Louis area and only one health system currently utilizes the role.
Oh, so I'm assuming this is clinical nurse specialist role, correct? Yes. So, well, that's a great question. I think what you have to do is be bold in talking to some of the nurse managers and articulating exactly what you can do for them. And what I have found is when you get your pitch together, the students in my program actually have to write a business proposal in their last semester, and they often use that business proposal to go in and secure a job. And I will tell you, the majority of them get offered jobs in places that didn't even have clinical nurse specialists, because a lot of nurses out there, particularly in leadership, because we're fewer in number, are not aware of the role and what we can do. And when they find out what you can do and how you're going to work with the patients that are high risk, how you are going to work with the nurses, how you are going to change some of the bad outcomes that you are seeing right now on your units or what we're experiencing in healthcare right now, they tend to think twice right away. So I think kind of working on your elevator speech as well as a business proposal. What are you going to do for them? Because everything is a business, and you have to be able to talk about the value that you are going to bring to the table. So it's really just kind of doing your homework. You have the competencies, and you're near the end of the program, so you understand what those competencies are. So now it's just important to get your proposal, your business pitch together, and then do some talking to some of the nurse managers, the nurse leaders. Send your resume to the chief nurse officer and get on their schedule and have a conversation. But you just got to put yourself out there. It's a different level when you get your master's and your doctorate. And the other APRN roles have problems finding jobs as well. But you've got to put yourself out there, and you've got to come up with your pitch on the why hire me, and you know, because we know the needs are there, particularly with what we know with the nursing shortage right now, a younger workforce. We have rates of burnout and lower well-being, and we're about to see the largest tsunami of seasoned nurses leaving the health profession. So, you know, we know the support for nurses is going to be there, and everyone wants to retain their nurses. So nurse retention, think of the ways that you would help retain nurses, you know, and improve those satisfaction scores. So many ways, different angles to attack it. So I hope that was helpful.
We have another question from Orlando Flores. He says, thank you for your presentation. I have been interested in becoming a CNS for over a year now and have searched multiple programs across the country. I currently work in a critical setting and would like to continue once I do become a CNS. I know there are some critical care tracks. Would those be more beneficial to apply for rather than obtaining my degree at another institute that does not offer the specialty track?
Yeah, so you don't have to necessarily be in a critical care track for the CNS. So what happens is it's adult gerontology, pediatric, or neonatal, and you will get those competencies that cover critical care, because most CNSs work in acute care anyway, so you don't have to worry about that so much. If you already have the critical care experience, then most likely you will want to take the national certification exam that is geared towards critical care CNSs. But so for example, the program that I run, I get a mix of critical care experienced nurses that come in, as well as those who have never practiced in critical care and have no desire to practice in critical care. So it doesn't matter. They come in. You may do your clinical experiences in critical care, or you may do them in non-critical care. So you're developing yourself for the role that you want to be in while you're in the program, which is really nice. I have some that are interested in wound care, so they're going to be with wound care specialists even more so in clinical hours. So you're really grooming yourself for that specialty role. And then when you get out, you have options for your national certification exam. The ANCC clinical nurse specialist exam is for those who do not have critical care experience. And the American Association for Critical Care Nurses CNS exam are for those who do have experience as critical care nurses. So you make a decision which exam you want to take, and either exam counts as your national board certified exam for you to get your licensure as a CNS.
Araceli says, I am in a CNS program and nobody knows what a CNS is. It's so frustrating. What is your elevator speech when you describe your CNS role?
Yeah, so just hang in there. Do not waver. They are very, very curious, and they're kind of jealous. Like, who is this person? You know, what is this role? And they're very curious about you. So just stand your ground. You are becoming an advanced practice registered nurse, and you are able to diagnose and prescribe care like the other APRNs, but you have additional training to help and support the practice of nurses, bring the best evidence to the bedside, and function as a systems leader, and you can improve all the inefficiencies that you see around you. So I hope that helps.
Cassandra says, with the focus on complex care or a complex patient, is it then the recommendation or suggested to have a minimum of so many years working at the bedside? I think they're trying to ask, like, how many years at the bedside is recommended before doing a CNS program?
Yeah, so this is the thing. So we're starting to see nurses come in to CNS programs right away, like right after their BSN. Now, the thing about that is when you start in a CNS program, you're going to take courses for the first year. Now, you're probably working full-time during those courses, going part-time most likely, which is what almost all students do, and you're working full-time. So by the time you get into clinical, which would be in the second year, you've now put in well over, you think of the hours in a full-time RN role, 2,000 a year. So now you're already about 3,000 hours as an RN before you start clinicals in a CNS, you know, in your CNS program. You're ready. You're ready. Now, most nurses, I would say, do practice for a few years and figure out what specialty they want to go into. You know, like, I want to be a clinical nurse specialist for older adults, or I want to be a clinical nurse specialist in diabetes. So you kind of, it's good if you can kind of hone in on that specialty so that when you get in your clinical hours, you can work with some of the best and the brightest in that particular setting, ER, critical care, wherever you want to go, or wound care, or pain management, or orthopedics, or neuro. You know, it depends on your specialty area. Then you can go into those clinical hours with some of those really high-level mentors and preceptors. So that's the only advantage, I would say. But I'm seeing more nurses come out of nursing school and they're ready to go. They're ready to come in, and I do not have a problem with it.
Great. That also answers Savannah's question, that is this something that a new grad can pursue?
Yes.
And then Bella asked, good evening, I'm an RN and I'm working as a visiting nurse and HAA instructor. I would like to continue the CMS. What will be your advice on where can I start?
Yeah, so you want to start with, depending on where you live, look at our program directory or look around for a CNS program that would be local. If you're not opposed to online, you could definitely get in touch with an online, you know, one of the online programs. And I would say call the program director or send an email to the school, or, you know, specifically asking for information to speak with the program director. If you go to many of the CNS websites for a school, oftentimes a program director will be listed with their contact information for you to contact them directly. So I would say be bold, send that email, make that phone call, leave that voice message and say, I'm interested, I want to talk more. And that's how you get the ball rolling. You start partnering with the program director. And a program director, like I'm a program director, and I also am the lead faculty for the CNS courses. So you're going to have me as a professor, as well as your advisor, as well as your program director. So, but that's how most of us function that way. And I know of these program directors because they're a council within our national organization. So I'm familiar with all of them, and they're wonderful people. So, but you just got to be bold and make the call. And, you know as much as you can about the CNS role. You know, try to get informed. Go to our website, go through our website, try to learn, what is the CNS like? What do they think about? What do they do? And so, you know, just kind of use your brain and your heart. You know, is this right for me? Is this what I want to do? And then once you decide, you won't waver. You keep moving forward, because the jobs are out there. It is such an important role. And I would just say, just keep moving forward. And just make that first step with making a call or sending that email.
We have a follow-up question from Orlando. He says that his current hospital does not have a CNS position. They would like to bring this role into the hospital as it can benefit the hospital, especially if they're reaching magnet status. They only have one CNS, but they do not currently work in the CNS role. Does any NACNS offer any support to help bring a position into a hospital? Like, do you maybe have resources for them to share?
Yeah. So we would be glad to function as a consultant for any hospital system that is interested in bringing CNSs in. And, you know, sometimes all you need is one CNS to create 2, 3, 4, 5, 6 more. So this can all be done. It's just a matter of your leadership reaching out to NACNS for that support. And we'd be glad to work with them. You know, it's sometimes the healthcare system has to then identify nurses that they want to help support to send back to school to become CNSs. So, you know, that would be another model to potentially pursue. So most of us have, some of the schools are seeing some of their highest population of CNS students right now, and then others, there are still openings. So there's definitely openings out there for more CNSs to get trained. The other thing I would think about is just approaching your own leadership and telling them, hey, I've learned about the clinical nurse specialist role, and I see benefits in having it. I'm thinking about pursuing it. Would you be interested in supporting me in that education? You know, because I see a lot of areas here on the unit I'm working on that could really use the support of a clinical nurse specialist. And then they get the conversation started that they would support you, you know, maybe even partially in the cost of a CNS program.
And he says, my last question, hopefully, the population I currently work with is both adults and teens. If I would like to continue to work with these populations, would I have to become dual certified in order to work with these two populations? Have people done dual certifications?
Yeah. Oh, yeah. So that's a tough question. And the answer is yes, because, so this is the thing. You can work with both of those populations, because as an RN, you know, maybe you're already certified in one of those areas already. I'm not sure, like have a specialty certification of some sort. But this is the thing. If you're an APRN, your scope of practice is different, because now you can diagnose and prescribe. Maybe you have privileges in the facility that you can order medications. But if your education is adult gero, then that would only be as an APRN for that older adult, or, you know, teens and up. It wouldn't be for a 12-year-old. So your care would be different for pediatrics if your APRN is not in pediatrics. I hope that makes sense, and vice versa. So yes, if you wanted to be an APRN for both and just swing back and forth, you would need to be certified in both areas. So it'd probably be getting your master's in one and then a postgraduate certificate in the other. Can be done. It's just more school, a little bit more work for you.
And that we have those questions that people pre-populated, and I think this is a good one. Is a CNS a good option for a research nurse?
Well, yes. I mean, it's a great option for a research nurse, because clinical nurse specialists function off data and evidence. So when I talk about being a systems level leader and being, you know, the leader of change, you know, you don't make change or do anything based off of opinion or I think this is going to work or trial and error. You dig into the literature and you learn how to read the results and statistics of research. And through all that, you decide what is the best interventions that we bring to the bedside based off that evidence. And a CNS learns how to do that, and you apply those rules, that evidence-based practice rules over and over and over again. And if you think about it, that is applying a part of the research process. Now, to be a researcher, like I'm a full-fledged researcher because I have a PhD, and I've had a PhD in nursing, which is the ultimate research role. That means that I can write for NIH grants, which I have, and which I've had one, and I have the full scope of research behind me. I've had oodles of advanced statistics and research methods, and I've done a dissertation, and so you've proven yourself. So that's the ultimate research nurse. You know, when you have a PhD, that's research. But a lot of what a CNS does is apply the rules of research. So could you be a research nurse as a clinical nurse specialist? Yes, you could. If you go on and get a PhD, you're at the very top. You can't get any higher than that. So that's what I would recommend. Get your CNS and then get a PhD so you can do research, because I think that's a wonderful way to go.
And I can add a little bit to that question too. So I'm also a CNS, but I am a DMP prepared CNS, and I do clinical research. But I have struggled because my doctorate program was not a research program. So I've just had to surround myself with really good mentors, a biostatistician, my nursing scientist at my institution to really help me be successful in doing research. So it is possible to do it. You just have to surround yourself with those good mentors. One of the questions in the chat, it says, hi, Mitzi, like Amanda, I am 2 semesters away from completing my course. However, I am abroad due to military life. I will not return to the U.S. I can't read that last part until 9 months after I complete my course. What can I do to maintain my skills up to date to secure a CNS job in the future? Will the gap in my resume be an issue?
No, I don't think it won't be an issue. You can use that time to study and maybe take your board certification exam. So, you know, that, because when you finish the program, you're going to take so many months, sometimes I would say roughly 2 to 3 months to then prepare for board certification. So that is hopefully something you could do during that 9-month span of time. And if you're still working in nursing or, you know, it'd be good if you still had patient contact, because after you've been through the program, you are going to see patients and the whole system through a different lens. And you're going to be identifying problems, things that you did not do necessarily as an RN when you came in and you had your set group of patients and they were your problems. You're going to be thinking and seeing more broadly. So I would say just continue to think that way. Think like a CNS. Read the CNS literature. Read what other CNSs are doing. Just stay connected with what CNSs are doing and see yourself in that role.
One of my favorite things to do is to subscribe to the CNS journal. And so that it comes out, I believe, every other month. And so it's really nice to read how other CNSs, what they're doing, and it sparks ideas and like how they solve problems in their institutions. And you can kind of learn from other CNSs that way as well.
Yes.
A question that they submitted was, what are some opportunities for entrepreneurship as a CNS in California?
Oh, that's a very nice question. So there are so many non-traditional CNS roles out there. So I mentioned Alyssa Shannon, who is the analog astronaut, with the Mars Project. But there are, when I was at the last conference in the fall with CNSs, I sat at a table with several other people who, one was a pharmaceutical representative, and now you wouldn't say that's necessarily an entrepreneur, but it's using the skill set of a CNS and the education and then doing something completely different, which I just love. And I think CNSs have that opportunity, just the versatility in the role. I mean, I would think, my main job right now is a professor and a policy professor, and the things that I do that are different, that I'm using that CNS education, that mindset in a different way. So, and then I also think so many CNSs with the state laws the way they are now have the opportunity to really open up their own practices and move away from payment system. You can have cash only patients. There are so many opportunities in mental health, well-being, so many opportunities that a CNS can really just have their own practice now. I mean, the scope of practice rules in the state are very much in favor of that. And you may say, but I don't really see CNSs doing that. And that's because healthcare systems have not caught up to their own state laws, and barriers within the system keep advanced practice nurses across the board. This is all of us, nurse practitioners just the same, from practicing at our full extent. So being an entrepreneur and branching off, opening your own clinic or partnering with another CNS and opening a clinic, or a nurse practitioner team or a physician team, it's just a wonderful, wonderful thing to think about. It's a lower percent that will do it, but it's pretty darn wonderful. Yeah.
I also want to expand a little bit on that, just because I have seen a lot of growth with our CNSs, because the skill sets you learn as a CNS just prepare you to do just a variety of things. Like the people I worked with became directors over patient education. They became the VPs of quality and patient safety, VPs of nursing excellence. Some are consultants. So your role that you have as a CNS, that skill set just applies very well to other jobs. Like right now, I'm actually not in a CNS job. I'm a project advisor to help a planning, construction, and design team build new hospital spaces. And so I'm taking my CNS skills that I learned in my job to this new role. And that's why I was actually recruited into that role, because of my skill set as a CNS. So it's good when I think about this role, because your CNS training doesn't just end there, like you're a CNS and that's all you'll be. Like there's so much growth you can do with that skill set.
Absolutely. Absolutely.
I don't see any more questions in the chat, and I think we pretty much covered most of the questions. I think you talked in your presentation about becoming a wound care clinical nurse specialist, what that path would look like.
Yeah. Yeah. I mean, it's if you come into a program and you know what you want to do, the program can be tailored to meet your needs. So when you write a paper, you write about that topic. When you're in clinical, we make sure you get clinical hours in that topic. So for example, I have a student right now who is very much going to she's going to go into a clinic, and they want her to do this as a CNS. She's going to be in genetics counseling. Well, part of that is a procedure. She has to learn these special kind of skin biopsies, which we're making sure she gets the practice in clinical now as a student. So when she graduates, she is ready to do that procedure and bill for it. So that's just an example of how you can tailor in advance, and just, that would be the reason to come into a program kind of knowing where your passions are and what you want to be, that if you have a little bit more time as a nurse, you can figure out. But some just know, sometimes you just know the kind of population you want to work with or the setting, and we can tailor your clinical and your work towards that specialty area. So definitely.
Well, thank you so much, Mitzi, for your great presentation. We are at time, and so if you have any further questions, please email Mitzi directly at her email, president@nacns.org. You could also reach out to the organizers of this session, and we can get you connected. Thank you, and have a great night.
Thank you.